Hello again, this is Madan Rehani, President IOMP, and now I'll be talking to you about the role and capacity of radiation protection experts and medical physics experts in ethics in healthcare. I will confine myself only to the case studies to give you an indication of the role and capacity. And I have taken the example of interventional procedures which are conducted in large part of the world in most tertiary care centers, and they are essentially divided into two categories: the in radiology vascular surgery, and in second cardiology electrophysiology. So if, for example, if I see the situation in the hospital where I work, the ethics are common. They are hospital policy and practice based. The safety culture also is common, and hospital practices and policy based. Quality and safety committees, we have a huge infrastructure of the same, starting from board of trusted on the top to the various committees you see here. At the bottom you see patient care assessment committee and quality oversight committee, and when I go a step further down, there is an excellence everyday coordinating committee and safety committee there. And when we go into further down the details, you see huge infrastructure of these safety and quality committees. So with that information on the structure, and also further down the excellence committees, we have regulatory readiness, institutional priority areas metric, environmental of care. So they connect to the safety committee. So what we want at the end of the day is that there should be a system for dealing with patients who exceed the trigger level set by either the state or the National Council on Radiation Protection and Measurement. So that is the requirement of the need in interventional procedure. Uh, we have requirements to inform the radiation safety committee every time, and follow-up of patients. We need to look at how, who, what, and when. Let's look at the situation of the two categories which I started with. The first category is interventional radiology and vascular surgery, and second category is interventional cardiology and electrophysiology. The first category is looked after by medical physicists in my hospital, and the second category is looked after by radiation safety officer or radiation protection experts. And when there were 2 points which I mentioned a couple of minutes before, that is, first is the information to the Radiation Safety Committee. Uh, when it comes to the requirements, state governed requirements require us in our state, every patient with more than 2 gray at the reference point to be reported to the Radiation Safety Committee. So they apply to both of these interventional situations. Both do it but differently, as I will mention in the coming slides. So medical physicists and radiation safety officers, they do it differently. And it took almost 2 years to change the practice to harmonize. So even if the infrastructure is good and in place at the institution level, hospital level, with ethical setup and quality and safety, the two groups which I am talking about, the medical physics and RSORP, have a different way to deal with that. And on the follow-up of patients, how, who, what, and when, let's look at this for both the categories separately. So the situation for interventional procedures conducted uh, is that RSO follows up the approach prescribed by the state. Medical physicists follow the approach given by NCRP, the National Council. Both are driven by local situations. Both do it, but they do it differently. And there is a partial change in 2-3 years to change the practice and harmonize. So the point which is coming out is that even if the whole framework is sort of established, uniform, ethics well laid out, but when it comes to group of people, they practice differently. For example, medical physicists have assessed in our hospital how the patients with more than 2 gray but less than 5 gray have changed over the year, the last 8 years, and similarly for those patients who are more than 5 gray, how they have reduced. So this was an analysis of more than 41,000 patients where they found that the percentage of the patients was lower in 2017 as compared to 2010 by threefold for dose in 2 to 5 gray and by 8.2 fold for dose more than 5 gray. Sorry, there is a typo. It should be 2010, not 2010. And there is another paper in which we found that the patients may have as much as 524 millisievert from a single procedure and 5 percentile values were established. So various publications by the medical physics group. So the problems are, despite the hospital highest emphasis on high quality and safety and having excellent ratings from state and joint commission audit and also audit by the American College of Radiology for Center of Excellence in our hospital, there are differences in approach as well as in actions. So do these differences impact patient radiation safety? That is always the question which one keeps in mind and one has to investigate. And if there are, why are there differences? So there is always resistance to change as one of the factor, a feeling that I am doing right and I have been doing it for XYZ years and there has to be no problem. There has been no problem with the state or the Joint Commission or other external agencies. Why should we change? So on analysis, our outcome is that preference by different professionals is remaining, whether it RPE, RPE, RSO on one side and medical physicist on the other side. Individuals involved and their traits are a factor to be taken into account. Do we work to achieve compliance or to achieve patient safety? So that is the difference in approach between two professionals. And this is a great example of everything excellent at the top, but may not be so at the patient level. So in summary, the same objectives, the role is different for two groups which we are talking, approach is different, the results and outcome is different, and these differences in approaches and outcome needs to be considered from ethical angle and from practice angle. Thank you very much for your attention.